السلام عليكم. السلام عليكم.
عليكم السلام.
كيف الحال؟
الحمد لله.
حياكم
السلام
الله.
عليكم دكتور، كيف حالك؟
السلام ورحمة الله.
الله يكرمك، يديك العافية.
منورين ما شاء الله.
الله يكرمكم يا أخي، الله ينور.
مهند, you are host now.
Okay, just give me a few seconds.
طبعا احنا فطرنا قبل دقائق.
هاي.
الصورة واضحة؟
كويسة, هاي واضحة.
طيب
الصورة واضحة والصوت واضح.
كده أحسن ولا قبل؟
كده أحسن. مرحبا بكل الحضور الكريم. السلام عليكم ورحمة الله وبركاته. نستنى بس دقيقتين لحد ما اللايف يبقى على الفيسبوك, وإن شاء الله نبدأ في our lecture today إن شاء الله. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. إن شاء الله الصوت يكون واضح. الصوت يكون واضح في طرفك يا دكتور؟
ايوه واضح. لا واضح.
أيوة. مرحبا بكم جميعا في واحدة من سلسلة المحاضرات اللي بتقدمها لجنة الأطباء السودانيين بالخليج. كل سنة طيبين مرة ثانية. الليلة إن شاء الله بنستضيف دكتور وهب الله كمال الدين. والصلاة والسلام على رسول الله. إن شاء الله الصوت يكون واضح. الصوت يكون واضح في إيكو. في الصوت بيتكرر في حتة. دكتور وهب الله كمال الدين خريج جامعة أعالي النيل, نائب اختصاصي طب الطوارئ. عمل في وزارة الصحة بالسودان, وبعد كده وزارة الصحة السعودية, بعد كده مستشفى الحرس الوطني بالدمام. يعمل حاليا في مستشفى ويلز الجامعي في المملكة المتحدة. حاصل على زمالة الكلية الملكية البريطانية لطب الطوارئ, وحاصل على حاصل على البورد الأوروبي, زمالة البورد الأوروبي لطب الطوارئ. عنوان المحاضرة حيكون Management of ED Patients, Emergency Department Patients during COVID-19 pandemic. نرحب بك دكتور وهب ونرحب بالحضور الكريم. تفضل.
الله يكرمك دكتور عمار، كيف أحوالك؟
الله يسلمك.
السلام عليكم ورحمة الله. الحضور الكريم كيف حالكم؟ أنا دكتور وهب الله، نائب اختصاصي طب الطوارئ، شغال في مستشفى ويلز الجامعي في UK. I will talk about the management of emergency department patients during the COVID-19 pandemic.
Welcome. طبعا حيكون في ان شاء الله interactive session، حيكون الاسئله والاجوبه في نهايه البرزنتيشن عن طريق الكويشن اند انسر ايكون اللي في الزوم، وعن طريق الشات، وعن طريق اللايف في الفيسبوك. يلا بسم الله الرحمن الرحيم، نتوكل على الله ونبدا.
طيب.
واضح.
طيب في البداية زي ما بقولوا الواحد بيتمنى إنه جائحة كورونا إن شاء الله تنتهي عما قريب. ما في شيء واضح، زي ما بقولوا ما نحبط الناس، ما في شيء واضح لغاية الآن، لكن ندعو الله سبحانه وتعالى إنه يزيل الغمة ويعافي الجميع ويشفي المرضى، و يعني نتمنى إنه الجائحة بتاعت كورونا تنتهي إن شاء الله في أقرب وقت ممكن. طيب الأوبجكتيفز بتاعت التوك بتاعنا، I want to talk about approach to the emergency department patients in our hospital. It's not only in Sudan, but in all over the world. How it is a suggestive approach, how we will manage the emergency department during the COVID-19 pandemic. This is the main topic and the main objective from this talk. Also, I'll talk about the management of COVID-19. We will go just through it, and we will also have an idea about other presentations which are not related to the COVID-19 presentations. But our main talk, it is about how to establish the emergency department and how to establish a triage system in the emergency department, or how to establish a parallel triage system in each emergency departments or in each healthcare facilities. As we all know, COVID-19 is unprecedented situation. Every time there is new things, it's a dynamic. Up to now, there is no clear picture about the disease itself or how we can manage it, and there's no even in the near future vaccine or treatment. Up to now, all the trials of the treatment which they have provided, there is no a good randomized controlled trial telling us that what we need to do or what is the protocol for this management. So we need to be safe. Our safety is our priority as a healthcare worker. The community safety is our priority. We need to be all together. We need to support each other, and we will not forget to remind each other about the PPE and safety aspect. First, let us talk about the epidemiology of the disease. As you all know, COVID-19 is a respiratory tract infection, newly emerged. It is a zoonotic disease, which is SARS-CoV-2. The other name is COVID-19 for it. because the first case reported in December 2019. That's why they gave it the name. So most of the people, they have just mild uncomplicated illness, and those are around 80% of the cases. 14% of them they need to be hospitalized, and 5% they need to be admitted in intensive care. Before we go how we'll structure our emergency department, let us just talk about transmission of the disease. And as we have said, it is a zoonotic virus, so can be inherited, infected from animal to humans, and from human to human. How we will get the infection from inhalation of the respiratory droplets, which is coming from coughing or sneezing, or it can be even through the formite or just contact of the patient or the patient's surroundings. There's also nosocomial transmission, and that's why we need to implement infection prevention and control in our emergency departments and in the whole hospital. And now almost we need to do it in the whole community. The incubation period, the median incubation period is 5 to 6, could be up to 14 days. The infection can be even after 48 hours from the, it can be up to 48 hours before your symptoms appear, and it can be also after 1 or 2 days after you have been completely resolved from the system. There is some cases reported that they have PCR positive in patients who have got no symptoms now. Erosion generated procedures. This is another additional risk for the healthcare systems. So what categories of patients do we need to consider in each emergency department? So either we will have an emergency admissions and management cases, or we have cases with other clinical presentations not related to the upper respiratory tract infection or not related to the COVID in general, and they need to be discharged from the hospital. So those are the patients which we will receive in each emergency department. Those who will be admitted, they need to continue management in the emergency department, or they require admission to the hospital. And for that, and during this pandemic, we need to create a parallel system to separate those two types of patients who are coming to the emergency department. And this is our main talk objectives today. So every day there is new information. Every day there is new statement. And this is the last Royal College of Emergency Medicine statement, which is released in 6th of May. Last week, or this week, at the beginning of this week. And the main aims of this is to how to reset the emergency department. And these are their recommendations for how to do that. Almost all the aspects of this statement, we will go through it in our presentation. I have thought about this presentation almost about 10 or 2 weeks ago, because of there's some cases went to the hospitals, and these patients, they've been directed to other hospitals, or those in some of the private hospitals also, they are not seeing patients with coronavirus. or those who are suspected with coronavirus. So that's why I thought about this presentation. And we need from each healthcare facility to prepare itself and to restructure its entrance of the patient and its entrance of the emergency department to have a parallel triage of the patients, so that everyone will go to the hospital, he will find the care which he needs. And that's why I thought about this presentation, and I need to just to present it so that we can help, at least by our talk, in establishing a good triage in each healthcare facility, either in hospitals or in PHCs, or even in the clinics, in the polyclinics. So the aim of this statement, that emergency department must not become a reservoir for the nosocomial infection. So they need to implement the infection prevention and control in each hospital, so that they decrease in nosocomial infections. Emergency department must not become crowded ever again, because at the beginning of this pandemic, even here in UK, there's no protocols of how to run the emergency departments. So all of these protocols and all of these statements, they are coming day after day during this pandemic. So even we are here in the hospital, we have suffered from this point. That's why there's no any issue. If we fail now, we need not to fail tomorrow. If we miss to manage the case now, we don't want to do it again tomorrow. That's why we need to sit all of us together and to share our ideas and our suggestions of how to improve the emergency department patients in our healthcare facilities. Just something I want to comment about regarding this point. I have been invited for 2 webinars from the Royal College of Emergency Medicine, and this is just for all members of the Royal College of Emergency Medicine. It's not just for me. So, and also I attended 2 other webinars in the EU SEM, which is the European Board of Emergency Medicine also. And all of these webinars held by the president of the Royal College and by the presidents of the European Board. And what they are talking about the experience of each country and the experience of each hospital in the UK, how they are running their departments and how they are treating their patients, the emergency, and how they are decreasing all of these and all of these infections, and how they are treating their patients, and they are sharing their ideas. And this is the concept behind this presentation. We need to share the ideas. We need to improve each emergency department, and we need to improve each healthcare facility, if it is private or PHC or hospitals. So what we need to do to provide a good quality of care for our patients. And one of the aims also, they don't want the hospitals to be also overcrowded. And the emergency care must be designed to look after vulnerable patients safely. And ED must be a safe workplaces for the staff. So this is a suggested or possible flow chart for the emergency department attendees. Any patient coming to the emergency departments, what we need to do at the beginning, we need to set an emergency department screening. So we need to set a screening outside the department or at the entrance of the emergency department. If this is not possible in some of the hospitals in Sudan, so they need to let's say that the entrance of the hospitals is not just direct to the emergency department. I know Umdurman Teaching Hospital, Bahri University Hospital, or Bahri Teaching Hospital, they have the emergency department. Everyone who can go, he will go direct to the emergency department. But there is other facilities which is not structured to do the same. So they need to put the screening at the entrance of the emergency department. So that's why we need from the screening nurse or the screening physician to sit in the front door. And what he will do, if we are talking about let us say definition of the suspected case or definition of the case, this may be just at the beginning of the pandemic, which there is no many cases, but at the moment now, which we are facing now, so everyone should be suspected if he has respiratory symptoms. I don't think so there is a role for those who had contact now or no. I don't think so. So we need just anyone with respiratory tract infection or respiratory tract symptoms or with fever, they have to be directed to a cohorted COVID area or cohorted COVID emergency department. So the definitions for that, either he has fever or he has upper respiratory tract symptoms. If he had none of these, so the one who will do the screening, he will ask the patient if he had any of these, and he has to check the temperature. He has to ask him about the symptoms, but he has to check his temperature. If he has fever, he has to shift him to the respiratory illness area. If he has no, and he has any other presentation apart from upper respiratory tract infections or from any respiratory, no shortness of breath, I mean no cough, no sore throat, and there's no fever after he check him, so he will, and he has another complaint or another presentation, so he has to shift him to the non-respiratory illness area. Again, from here, this is just for the screening, and when he will shift the patient to either of these areas, there will be another triage there. So they will re-triage they will triage the patients. Let's take those who will come with respiratory illness. They have to assess their severity and to check if the patient is severely ill or non-severely ill, or non-seriously ill, I mean. They can put a protocol for that, but this is just a suggested one. Anyone with oxygen saturation less than 94, less than 92 in some of the literatures. Those who has COPD, 88% is the cutoff point, or who has news more than 3, which is the national warnings symptoms, more than or equal 3. So those they will be seriously ill and they have to be cohort to a different area. Those who are not seriously ill, they will also be treated accordingly. So let us finish from this slide and then we will go for each of these. Again, those who has no any respiratory illness, they need to either triage them either to red flags or non red flags. So they need to be treated in the emergency department, or just they need to be reassured or do some labs for them and then either send them home or provide the definitive care for them. So let's take those who has respiratory illness and who are seriously ill. You do an investigation and treatment accordingly. The chest X-ray plus or minus CT. Not to go for CT from the beginning unless it is clinically indicated. Provide high flow oxygen. Target oxygen saturation more than 94 and more than 88 in COPD. Restrict fluid management. And those who are pregnant ladies, I think the target for oxygen saturation is more than 95 or 94 to 95. According to the management and the investigation which you have done, either you, if there is a bilateral chest X-ray findings, or the chest X-ray is not inconclusive for COVID, so you need to go for CT for them if they are seriously ill. And according to the result, you will either treat as COVID probable or non-COVID disease. And those who are COVID probable, you will admit them to the cohorted ward. Those who are non-COVID disease, you will admit them to the HDU or the general ward according to their severity. Those who are not seriously ill, with oxygen saturation more than 94, more than 88 in COPD, and who have NEWS score of less than 3, you will also assess them clinically. You will do chest X-ray if it is indicated, and according to the assessment and investigation, either they are COVID or non-COVID. Those who are COVID but who are not seriously ill, as I think at this time, we don't want to admit them, because almost most our capacities in the hospital beds in the hospital which are provide treatment for COVID patients is almost every day decreasing. So those who have COVID and not seriously ill, you need just to isolate them at home. This is what we are doing here in UK, but looks like we need to implement this one also in Sudan. I know it is difficult to home isolate in Sudan. It's not that difficult, but I don't know, maybe behavior of the people or a lot of stuff which is going on, or the social status. So we need to tackle more on these patients. If we need to home isolate them, we need to educate them how to do home isolation. I will talk about this later. Those who are non-COVID, we will treat them accordingly. We'll come to those who have no respiratory illness, and as we have said in the severity assessment, either red flag or non-red flag. And those who have red flag signs, we need to assess them in the emergency department and treat them accordingly. If no need for them to be in the emergency department, we will discharge them from that point and advise them to where they'll go. So the main thing about this one is to have a binary triage. So we need to have 2 emergency departments. We have to separate those 2 emergency departments in each hospital. Each hospital, they should implement this. Because if we didn't do so, we will end either we will close the hospital, or we will not accept either COVID patients or non-COVID patients. And I think it's easy to be managed if we need to do so. And it is not only the responsibility of the Minister of Health. The Minister of Health, they need to arrange, they need to put the protocols, but also protocols needs to be done in each hospital. So the manager of the hospital and the head of the departments in all the side of medicine, I mean surgery, ops, infectious disease, orthopedics, they need all to sit and to structure how they will do that. So we'll go now and we'll talk about those who have respiratory cohort, the priorities for them, what we need to do for them. So we need to, our environment and our equipment to have a good staff dealing with these patients. Severity assessment of the illness. We need to establish differential diagnosis based on the examination, as we have said. hematological, biological, and biochemical, and chest X-ray findings. CT, unless it is indicated, not to go directly to the CT. We know now there's some of the COVID in the early stage. It will not appear only in the CT, but if they are not seriously, no need to go for a CT for them. So let's talk about the screening. We have just structured it. So screen and triage at all points of access of health system. So it's not just in the hospitals. I know at some point they have closed even the PHCs, they have closed the clinics, and I don't think so this is the right way. We need to open all the health system to provide the care for the patients they need, and to decrease the load for the hospitals and for the emergency departments. Otherwise, we will have a crowdedness emergency departments, and we cannot manage at some points. So we need to open all the clinics, we need to open all the primary health care with implementing of the screening and triaging at these points. So it is not just to open them, no. We need to open them and to provide a good care which will decrease the COVID-19 illness. Another thing is to set up the telephone hotline, and I think this is running now. Maybe there's some difficulties with it. There's not enough staffs or so, but at least they are doing their job. We can audit it, we can enhance it, and we can improve it. So I think the local call is 221 and 9090 for those who will call from the state. And they have to provide not only they have to provide even the information about the disease, and if the patient he had symptoms and he has no any symptoms or signs of severely ill, they need at least they can just advise them to home isolate and to come to the hospital if it is needed. The care for all COVID-19 patients in the designated treatment area according to the disease severity and acute care needs, and at all first points of access to the health system, apply appropriate infection prevention and control measures, as we have said earlier. We will talk about this one later also. So all it is here in this slide. So infection prevention and control measures for patients who are suspected or confirmed case of causes. So first of all, we need to instruct our patients if he has any severely ill, or he has not severely ill, but you shifted him to the cohorted area, you need to provide him with a mask and to advise him for social distances while he's waiting to be seen. And also you have to advise him about hand hygiene and respiratory hygiene. If he will cough, how he will cough, and either you'll provide him with tissues, or just we will advise him to use his elbow with closing in it so that he will cover his respiratory droplets, or all of these stuffs. We need to apply droplet precautions and contact precautions, and this is just by hand hygiene for the healthcare worker, surgical gown, no need for the long sleeve one, only the short one will do its job, and surgical mask also. If there is a goggle, it will be better if you wear it. And you need to know the 5 areas of hand hygiene. So if you had any contact with patients before touching the patient or after touching the patient, if you touch the surroundings. In all of these steps, you need to apply the contact precautions. Airborne precautions, if you want to perform any role-generated procedure. So if you want to intubate, to do a CPR for the patient, if you during the cardiac arrest, and you need to wear full PPE, which is including the long sleeve surgical gown and gloves, which has to cover this area. And I mean the sleeve, and also you need to wear the N95 mask. So let's go and talk about the disease itself. So high-risk patients, we all know any respiratory conditions, underlying respiratory conditions, asthma, COPD, diabetes, those who are more than 70 or more than 65, cardiovascular disease, hypertension, chronic kidney disease, immunosuppression, and pregnancy. Symptoms, as you all know, most commonly patients will have cough, fatigue, sputum production, fever, shortness of breath, myalgia to some extent, and headache, sore throat, and chills. There is less common symptoms, nausea and vomiting, diarrhea, shortness of breath and diarrhea. They found it in more severe cases, and almost they have died, but this is not in general. Overall case fatality is 1 to 6% from some countries, but I know at some time in Sudan it reached up to 13. And this is from the WHO website. So clinical syndromes associated with COVID, mild illness could be just pneumonia or severe pneumonia, ARDS, some patients present with sepsis or septic shock, exacerbation of any chronic disease. And recently from the study which they have done post-mortem, they found that there is thromboembolic and neurologic complications for some of the patients. What we need to do from investigation point of view for blood count, lymphopenia, leukopenia to some extent, and if there is co-infection, the WBCs will be high. In some cases reported low platelet, and is associated also with severe disease. UNEs, acute kidney injury can happen. LFTs, some of the liver enzymes also found to be high in some of the patients. We need to do coagulation, ECG and TROP-I, because myocarditis case is also reported. CRP and procalcitonin, which is too important, especially the procalcitonin, and because it will differentiate the viral from bacteria. The procalcitonin will be raised only in bacterial infections. Viral infections will not cause any reason procalcitonin. So ferritin level, LDH, CPK also reported in severe disease or in severe cases. D-dimer, most of the patients, they have high D-dimer, and those who have more than one is associated with severe disease. You need to do VBG and ABG if the patient is hypoxic. The chest imaging, chest X-ray and CT, as we have said earlier, in the first 2 days, the chest X-ray will be either normal or there will be ground glass opacities. And 5 to 10 days, there will be obvious opacities, and most of these findings are bilateral. And after more than 10 days, there will be a consolidation. So unfortunately, regarding the treatment, there is no specific vaccine, there is no specific treatment up to now. All the trials done is not a good trials. There is no any randomized controlled trial that telling that to use which medicine up to now. Hope in the near future that will be happen. So mainly supportive care, counsel observation is most important. Early recognition of those who are at risk, to provide them with the clinical ventilation or the good supportive care which they need if they are in sepsis. Or those who have fever and they are in areas of endemic of malaria, they need to be tested for malaria, like in Sudan. So regarding the discharge from the hospital, some they said after 2 swabs, 24 hours apart, but even the PCR is not highly reliable, so it's almost 70% reliable. That's why I don't think so there is a need for testing patient twice if he has no symptoms at the moment, so we can discharge him. As we have said, hydroxychloroquine, azithromycin, there's trials, but it's not that good trial. Some they are using tocilizumab, and this one's interleukin 6 inhibitor, sarilumab, siltuximab, remdesivir. There is a new study suggest to use remdesivir, but also is not a good study. Plasma, there's some of the hospitals now, they are using the plasma of those who are infected with COVID. They are taking the antibodies from and they are providing it for patients. And all of this, it is just up to now, it is almost trial. Monitoring, you don't want to be near to the patient, so you can use just Abu scale. You can talk to them from abroad if it is not necessary to examine them. You can use the pulse oximeter, blood gas analysis, news and pews for the adult and pediatrics. It's just to use them for the monitoring. Oxygen therapy. So oxygen, patients with severe acute respiratory illness who are distressed, hypoxemic, you need to give them oxygen. You can use the nasal cannula or high flow nasal cannula, and you can use also the normal mask or the non-reservoir mask. You need to monitor them with pulse oximeter and naive, as we have said, and if that's not helpful, so and some of the patients who develop respiratory failure, you need to go further and to treat them with clinical ventilation. We will talk about it later. So as a conservative measure, you can give fluid to the shock patients. Try to restrict it if the patient not in shock or not hypotensive. Type antimicrobial, you will just give it for those who have sepsis or who have obvious consolidation or local pneumonia, and it is according to the protocol. And if there is any other influenza, you can use the oseltamivir, but it's not effective in the COVID. Type if the patient is still, he needs oxygen more than 5 days, and every other symptoms are fine, and most of the cases they report the need for oxygen for almost 10 days or more than 10 days. But if they reach the target with just nasal mask or nasal cannula, you can just provide it with them. Otherwise, you can go further. So those who have hypoxia in spite of oxygen supplementation, in spite of 15 liter or on non-rebreather mask, then you can implement mechanical ventilation for them and use low tidal volume and the plateau pressure not to be high. So less than 30 is the target. In children, less than 28. In adult patients with severe ARDS, you can use the prone ventilation, and you can use this on 12 to 16 hours per day, so almost if he is sleeping the other hours. So it's almost every day. Also, you can use ECMO if it is available. Inline catheters for airway suctioning and clamp endotracheal tube when disconnecting the tube, when disconnecting the ventilation, so that you will decrease the aerosol generated infection in the hospital staff. We'll talk now about the VTE prophylaxis. You can use low molecular weight heparin or heparin, and almost every patient for admission, you need to start him in VTE prophylaxis, and the dose for that is not the standard dose. You need to start them on an enhanced dose of VTE prophylaxis. As we have said, there is a thromboembolic phenomenon of the disease. And in some of the centers, those who have D-dimer more than one, they will treat them not prophylactically, so they will give the treatment dose. You need to actively mobilize the patients early in the course of the illness, so that you can prevent the weakness, especially in those patients who are needed to the intensive care. Provide them with H2 blocker or PPI proton pump inhibitors to increase the risk for GI bleed or ulcer. You need to turn them every 2 hours to decrease the pressure. So this is the enhanced dose of the enoxaparin, and it depends on the patient weight and the creatinine clearance of the patient. If his creatinine clearance is less than 15, we need to discuss with the nephro. Corticosteroids is not recommended unless in shock patients. You can use just low dose steroids or in asthma and COPD. Also, you can use corticosteroids in pregnant women after 24 weeks of gestation, from 24 to 34. And even this, you need to discuss it with the pregnant lady, because there is a high risk of getting worse. The disease itself will get worse if they start on this. But the pregnant lady, she's the one to decide if she will take it or not. What else? Immunoglobulins in patients with shock, because at that time we will not know from where the infection is. Patients with cardiac arrest. And just let's talk about cardiac arrest. So, patient with cardiac arrest, if the patient presented to be arrested from the beginning, so you will shift him direct to the cohorted area. It's better not to give the risk to the other staff. So you will direct him to the cohorted area. You will presume that he had the COVID. He arrested because of the COVID, even if there is another obvious cause. So, if he's being in the department, let's say he came with chest pain, and you shift him to the non-cohorted area, and you start your management for him before you do the X-ray or before he arrested there. So you need to shift him from this area to the cohorted area, either the resus or the other cohorted area, which is the patients who are suspected to have COVID, and then you can start your management for him. If he is being arrested and he's under monitor and you need to shock him, you can start shocking him, but don't do any other AGP if you are not in full PPE. You need to take care of the patient's family and friends, because for sure especially in Sudan, they need to talk to the patients, and they need to see him, so you need to speak to them and let them know politely that will affect their health and will affect the community health. I have some advice for those who will be discharged from the hospital. So they have cohort respiratory illness, but they are not critically ill. So you need to discharge them and they need to be home isolated. I know now they are admitting in other hospitals for isolation for 14 days or after they get relieved from the symptoms, but we afraid from at some point there will be no capacity to admit every patient. So what we need to do? So you will isolate them at home for 7 days when their symptoms start. So the 7 days started from the day first the symptoms start. Till when? Till the for 48 hours after the fever or after the symptoms. And those patients who are home isolated, you will advise them. And I think the home isolation in Sudan is easier than any other areas because most of Sudanese houses, they have a separate saloon and a separate bathrooms for the men and for the women. So it will be easy to isolate yourself if you want to do so, of course. Those household members who have been in contact with you before you are being suspected with COVID, they need to isolate themselves for 14 days. If any one of them get the symptoms before the end of 14 days, so he will count from the beginning for another 7 days as the first one who had, unless there is no direct contact with them. So what you will tell them also, move any vulnerable individuals out of your home. Let him stay with his friends, with other family in other house. If not possible, stay away from them yourself as much as possible. You will advise him about the hand hygiene and to cover the coughs and sneeze. Those who another advice for them is that if at any point after discharge you feel that you are getting worse or your symptoms or you can't cope with your symptoms or you feel any other symptoms which is not there and you think that you are severely ill, you need to come back to the hospital. They are excluding the cough from the symptoms because almost the coughs will continue for sometimes more than 3 weeks. So when we are telling that the symptoms will stop, is not including the cough in it. Also, they can contact the public health in the numbers which we have provided earlier. And advice about their symptoms: rest as much as you can, drink plenty of water, use paracetamol if there is fever, and you can do breathing exercise. Now we'll talk about the, so sorry, looks like we have went out of the time. Let's talk quickly about management of non-respiratory cohort diseases. Aim to manage without admission as much as possible. Use the capacity from the other specialties. As we know now, almost all of the elective work in hospitals is being stepped down. So what we need to do, we need to take all the physicians from those specialties and we will ask them to cover the emergency department. So if there's any patient, let us say he has chest pain, if he is looks like it is typical chest pain and he had any ECG finding, and let the internal medicine physician or the internal medicine registrar or the internal medical officer to deal him from the beginning, instead of letting the emergency department or the emergency physician take a lot of time and then he will refer again. So use the other specialties during this pandemic. Bring them to the emergency department and let them cover the cases according to their specialties. Those who have coming with trauma, let the surgeon to see them. Obvious fracture, let the orthopedic to see them from the beginning, and they have to do their best not to admit unless it is necessary. Make appropriate use of staff most at risk to their own health from coronavirus. So if you use the other specialties and you ask them to cover with you the emergency departments, and I think each hospital, they need to sit together, each head of department in each hospital, they need to sit together and to distribute the schedule of the physicians to cover these two emergency departments, the cohorted and the non-cohorted area, so that they will provide a good quality of care for the patients, and at the same time they will give a good time for those who are in the emergency department or those who are in the other specialties to take a good time of rest so that they can come for the other shifts in a well health, so that they can prevent themselves even from getting the infection. So we will talk about these specialties one by one. Those who have pneumonia, COPD, without oxygen or non-invasive ventilation requirement may need just initial antibiotic, and then you can discharge them accordingly. Those who have bronchial asthma and their peak flow is more than 75% of predicted, you can discharge them. Even if it is less than that and you treat them and it build up to more than 75%, you can discharge them. Pulmonary embolism patient without any physiological compromise, you can discharge them. Patient with CNS, any patient with stroke, residual deficit, not affecting the activities of daily living, so you can discharge them. TIAs, they can be seen from the beginning by the neurology or the internal medicine physician, and they can discharge them, no need to admit. So the point of this is to decrease the threshold for admission so that you will prevent the patient himself from getting a nosocomial infection, and you will decrease the load to the hospital and decrease the load to the emergency department. That is why just we need to run through it, and each head of department, they have to sit to and to put a protocol for all of these emergency cases. Patient with head injury and cognitively impaired on anticoagulation, done CT, normal, there is no any bleed, you can discharge them. Any patient with seizure who has recovered, you can discharge them. Those in the gastro, any hemodynamically stable GI bleed, you can use the Latchford score, so you can discharge them from the beginning. If there is a gastro physician like Dr. Ammar, you can discharge your patients from the beginning. Any patient with gastroenteritis.
ده اللي قاعدين نعمله حاليا.
ايوه بالضبط كده. Patient with gastroenteritis who have no kidney injury, you can, and they tolerate the oral fluid, you can discharge them. Those in the cardiovascular, new non-ventricular arrhythmias or dysrhythmias in general are now in rate control. Those with ACS without any elevations dropping in after 6 hours, you can discharge them. Syncope without any ECG conduction defect or rhythm disturbance, or there's no hypertension, so you can discharge them with the Holter monitor or just follow up in the PHC or whichever is available. Patients requiring physio, analgesia alone, any upper limb fracture, any fracture in the lower limb, apart from the femur, tibia and calcaneum, those can be discharged. It's just POP. Dislocation after reduction can be discharged from the beginning, can be seen by the orthopedic physician from the beginning. So it will decrease the load to the emergency physician, decrease the load to be seen by the specialty, which is good for the patient and which is good for the emergency department itself. Any minor stable vertebral fractures can be discharged. General surgery, renal colic, pain control, discharge, abdominal pain, normal CT, no need to wait. Abscess, not showing any signs of sepsis. If it's not that large, so you can discharge them with antibiotic. Hematuria without any clot retention, hypotension, or anemia, they can be discharged from the beginning. Bacterial infection, if the immune score is less than or equal 3, give the first antibiotic and discharge them. Patients toxicology, we don't have much toxicology cases in Sudan, but if there is a patient like that, either incidental or accidental, you can monitor them for 6 to 12 hours and then you can discharge them. End of life care, in Sudan, we are not discussing end of life care with our patients. I don't know if there's some of the physicians do that now, but long time ago, almost 10 years ago, now shows that how old we are. We are not doing any end of life care discussion with our patients. And in this pandemic, I think if there is any patient you think that he will not get benefit from the treatment which you will provide to him, or he will go back to his life with a condition more tolerable than the presentation which he came with, there's no any problem if you discuss this one with him. So it's just simple. You will tell him about what you think, if we have done CPR for you, or if we have put you in mechanical ventilation and we don't seem so there will be a benefit, or if there is a benefit, you will not be back to the same life which you are in now. So let him just take the decision if he need to do to receive the care which he need or not. Any patients of these presentations which we have talked about, you saw in the emergency department and you think that you will discharge him, you need to arrange appropriate follow-up plan for them, either by phone, by Skype, as we have seen in some of the patients from Omdurman, I think, Omdurman Teaching Hospital. And also today I have got a slide. I want to upload it, but I didn't have time to upload it. It's showing that there's some of the physicians, some of the registrars in the other specialties, they are arranging WhatsApp clinic to follow up their patients and just to advise them if they need to come to the hospital or no, which is very good actually at this time. These are the references for this presentation. It is from, as you have seen, WHO, Royal College of Emergency Medicine Learning, Royal College of Emergency Medicine, and England NHS websites.
Thank you, Dr. Wahballah, very much for this nice presentation. I think, mashallah, you cover most of the aspect of it, and really very appreciated effort. you have given us good examples. I hope my voice is clear.
Yeah, it is clear.
Yes. You have given us a lot of examples of diseases that can, of diseases which its management can be delayed or postponed in order not to crowd the ER with cold cases. Also, I think what I got from your presentation, it's a good chance for implementation of a scoring system, not for implementation, for more implementation of the scoring system, because it reduced the time of patient assessment, actually, and most of the time it gives the right decision whether to admit or to observe or to discharge. Another thing of which I got from your presentation is that it is a time to prioritize our patients. I mean, whom should be which type of patients they should receive the health care. Like some patients, until now we are not discussing the DNR with the patients or relative in Sudan, and in the future, in the near future, I think resources will be very limited, health care resources in Sudan or out of Sudan. So I think prioritizing which patient should receive this type of medicine or this type of intervention should be one of our main objectives in the future. I would like to give the chance to our audiences. Mr. Safi, Dr. Safi Al-Rifai, unmute and share your question with us. دكتور الصافي تفضل. دكتور الصافي.
You can take the other one.
Yeah.
هاي
دكتور أيمن عبد الله. دكتور أيمن عبد الله تفضل.
Those who are not available, you can check the other ones.
Galaxy Note 5.
السلام عليكم.
السلام ورحمة الله.
Sorry, my name is Dr. Abu Bakr.
أهلا دكتور أبو بكر تفضل.
I would like to thank you personally for organizing such amazing meetings. It's really very useful and very informative. I'm very happy to have Dr. Wahab among us. Thank you very much, Dr. Wahab, for the amazing talk. And as far as you are practicing in the UK, I would like just to ask you some questions about your practice there. I mean, there's a lot of questions regarding the topic because it's very tentative, and the topic itself is very challengeable because there is uncertainty. Now, I just want to ask about those patients who is, special cases, just like those who's organ transplant. Those people, they are vulnerable. They are all on immunosuppressant therapy. So when they come with the COVID and they obviously approach the ED when they have severe disease, I mean, if there's any special measurement dealing with them, this is question number one. And number two, nobody is sharing any data regarding the pregnant ladies with the COVID disease. I don't believe that at all. There is no pregnant ladies with COVID and some complications as well. And the other dilemma is those who is on novel anticoagulants therapy, just like dabigatran or rivaroxaban for a reason or another. When they came to the ED and you need to give them anticoagulation just in a prophylactic doses, what you usually do? I mean, do you stop the medication, you revert them, you start them on, you ask them to continue? And one last point, I would like to disagree with our host regarding discussing the DNR in our future. Personally, I do believe that only Allah subhanahu wa ta'ala has the right to take lives, and we should not decide whom should go for a good intervention. I think our duty is to provide the maximum, our best for all our patients, no matter what resources we have. Thank you very much for the opportunity.
Thank you very much. Dr. Wahab, I think we lost your video. We lost the video from your side.
I don't know, I'm seeing myself.
Yes,
Yeah.
now it appears.
Okay.
تفضل.
طيب شكرا جزيلا دكتور أبو بكر، كيف حالك يا أخي؟ بالنسبة ل أول سؤال هو اتكلم عن الناس اللي عندهم organ transplant who had COVID and who had severe disease. Those who will treat them as any patients who is at risk. So if he had any organ transplant and who had severe COVID, he will receive the treatment as it is. There's no anything to prevent him from the care which he need, unless he is severe elderly or he has any other comorbidities, and we don't think that he will get benefit from mechanical ventilation. We don't think that he will get benefit by admitting him to the intensive care. So we will discuss the end-of-life care with him if he is critically ill, and we can't say that he will get better. So those are the patients. If they are severely ill, those who are is the patients which we need to discuss the end-of-life care with them.
Dr. Wahab, here is some area of confusion between people. We are not speaking about withdrawing treatment. If treatment already initiated, no, there is no right. There is no one who has the right to withdraw treatment. But we are talking about doing DNR when it is futile.
Yeah, exactly. That's why maybe there is this point actually, there is a lot of debates about it, but it's clear. If you don't think so, you are as a physician, if you don't think so, the patient will get benefit from the treatment which you will provide to him, you need to speak to him about that. Maybe you will provide the care which he wants, or you think that it can be helped. But if there's no way, or if it is futile, as you have said, so you need to discuss it with him, and it's your decision to speak to him. But as I think in our communities, it's not your decision to stop it from him, but you need to speak to him, and you can even convince him about your ideas about this point exactly. Regarding the pregnant lady, Dr. Abu Bakr, you didn't say which question you want, but if you are, because I have attended the presentation from Dr. Samawal, and I think you have a question about using the prednisolone and the VTE prophylaxis in pregnant lady. So the prednisolone in a pregnant lady, you need to discuss, as I have tackled this one in the my presentation, if you went back to it, so that you will save the time, or I will mention it for you. So if she came after the 24-week and you think that she has severe disease and you want to section her, because by sectioning her, you will treat her also and you will save the child. So what you need to do, you will need to provide corticosteroids so that the child will improve his lung maturation, but this one will affect her health, and and the corticosteroid will let her get worse in the severity of the disease. So she's the one, she has to decide if she wants to take it or not. You have to discuss it with her. You will not just give it to her like that, but you will tell her clearly, I will give you the corticosteroid. We will improve the maturation of the lung of your child, but it may affect your condition and you may get worse, and we don't know what will happen next. The VTE prophylaxis, as we have said, we are here using the enhanced dose of enoxaparin. We are not using just the standard dose, and there is a slide about this one. You can go back to it. About the dosing, it depends on the creatinine clearance and the body weight of the patient. Regarding the rivaroxaban and apixaban, those patients who are on rivaroxaban or apixaban, they are already, you will not afraid from, unless they have bleeding. If they have bleeding, yeah, you can, there is some antidotes for both of them you can use, and you can stop them for a while. I don't know exactly how many days as the protocol said, but if there's bleeding, you can stop them. But if they are already on rivaroxaban, so at least they will help their condition regarding the VTE.
Okay. There is a question about what precautions can we only suit to Sudan?
I didn't understand.
At the level of ER.
At the level of AR, I have talked about this one. If you went back, maybe I didn't touch it deeply. So the precautions regarding the PPE or what they want exactly, precautions. What precautions they want?
About triaging, I think this is by Dr. Muhammad Taha. If he can clarify his question.
You can.
If he's hearing us.
Yeah.
I'm not sure if he's around. Dr. Muhammad Taha. I think he's not around. Dr. Abu Bakr, he raised his hand for another chance.
Yeah, you can give him.
Well,
Dr. Abu Bakr.
thank you. Yeah, thank you very much, Dr. Wahab. My question was totally different, Dr. Wahab. I just regard those people who are vulnerable and who are, organ transplant. I just wanted to know what is basic treatment used to provide to the level of the ED. I know that is a very complicated cases, and you need an input from other specialties. But like a ER physician, if I encounter such patients, and fortunately I do not see them so frequently, what you used to give there in the UK? This is number one. And regarding the pregnant ladies, I just only wonder whether you have in your practice or you don't have. That's the thing. And those for the people who is coming on the dabigatran and on the rivaroxaban, my question was clearly you can start them on the low molecular weight heparin. You can switch on without any other specific measurements. That these actually the questions which I needed to know. What is your practice over there in the UK? Thank you very much.
Okay, you're welcome.
Thank you.
Okay, شكرا دكتور أبو بكر. طيب بالنسبة للorgan transplant, what we are doing in the emergency department, we will treat them as we are treating any other vulnerable patients. So what we will do, we will provide oxygen if needed, and if they are not responding to the oxygen or they didn't touch the target, so we will admit them for the cohort ward or the intensive care to provide them either the mechanical ventilation or if they are in sepsis or so they will treat them accordingly. There is no specific treatment up to now, either for any patients or for those who are vulnerable. So we will treat them supportively. If they are hypotensive, you will give fluids. If they have sepsis signs, you will start them on antibiotic early in the first hour. You will provide oxygen as by the requirements and as by the target, and we will admit them directly. We will not, in the emergency department itself, we are not keeping patients to wait more. So we will admit them directly from the beginning. We will not even wait for the blood results to come. From the beginning, if they need oxygen and their chest X-ray, there is a finding in it, and we will just take the blood, start the oxygen, give the treatment accordingly. If they are febrile, we will work them as sepsis patients, so sepsis 6, as you know, and we will just directly admit them. There's no specific treatment, even in the hospital. All the treatments specifically for COVID, it is just trials. There is no up to now well randomized controlled trial asking to give whichever treatment is available. So all they are doing trials here, but there is no specific treatment up to now. Regarding the pregnant lady, I don't know what he said about the question again. He's asking if I have practice. So pregnant ladies, actually we have a separate emergency department, so they are being seen by the obs and gynae from the beginning. Or if they came to our department, we shift them to the obs and gynae wards from the beginning. So we don't have much experience. And also the patients with rivaroxaban and apixaban. I don't know if there is any of the protocols telling what to do about them, but I didn't face by a patient like this before.
Dr. Nasser, unmute yourself. Dr. Nasser. دكتور ضياء عجيب. دكتور ضياء عجيب تفضل. دكتور ضياء عجيب. Anyway, I think the previous question from Dr. Muhammad Taha, what precautions can only be sought to Sudan at the level of ER? How ERs in our hospital can be rearranged to match that? Yes.
Yeah, okay, I got the question now. So what we need to do, we need to put a screening team outside each emergency department. I prefer the most senior one to be in the front, okay? So ask either physician or a senior nurse to sit in the front. So, and they need only to have wear their PPEs, sit in the front, have the thermometer with them. So they will check the temperature of the patient. They will ask them what they are presenting with, and if it is a cohorted presentation, so you will shift them direct to the cohorted area. If they don't have any of the COVID symptoms, you will shift them to the other areas. So you need actually 2 emergency departments. If you don't have, you need to restructure your emergency department so that you will get 2 entrants, one for the COVID, one for the other presentations. If at any point you discover that this patient, he had any symptoms, but he is in non-cohorted area, you will shift him immediately, provide him with a mask, and shift him immediately to the cohorted area. Any patients you shift him to the cohorted area, you will start your management from that point. So what you will do, you will provide him with a nasal mask and let him wear it correctly, and you will advise him about the social distancing while he's waiting in the emergency department to be seen. And you will talk to him about the hand hygiene and the respiratory hygiene, how he will cough, how he will prevent the infection from the others. So this is what they need to do. Any hospital, and I think they have to do that in each emergency department. At the beginning in our hospital, what we are doing, we sent a screening nurse from the beginning, and those patients who have COVID symptoms, they will be directed to one room, which is open from outside. It's called the decontamination room. And it is only one room. The patient will enter, will be assessed there, and from there, he will either be discharged back or he will be admitted to the cohorted area, and then he will be worked up at that point. But when the things get worse and there is a huge number of patients coming to the hospital, we have changed again our plan in the emergency department. So there is no one room will take them. So we opened, there is we have here the emergency department or the old emergency department, and on the other point we have a trauma clinic, and this trauma clinic is dealing with the trauma clinic. After 1 day or 2 days you will refer them, and there is a physicians, they are sitting there from the surgery and trauma, they are seeing the patient. So we remove all of these clinics because it's not working anymore by the same way, and we shifted to the green area or a non-cohorted area. So we open it as another emergency department in the same building, and they are separated from each other. So this is what we need to implement in each hospital in Sudan, so that we will have the quality of care provided to the whole patients without anyone telling them you need to go back to other hospital, without anyone telling them you need to go back to the community. We are not taking any case of COVID. We are not taking any case of other diseases. Now we are dealing with COVID only. And I think all the hospitals in Sudan, especially the big hospitals, Universal the Bahri Teaching Hospital and Durman Teaching Hospital, they have the buildings to separate all of these, what we are talking about. So they can arrange that. They just need to sit together and arrange how this one will be implemented in each hospital. This is my idea about this one.
Yes, I think we have the spaces and we have the rooms.
Yeah,
that can be utilized.
Even the wards. Bahri Teaching Hospital, there is many wards for the medical patients. There is many wards for the surgeries. There is many wards for the orthopedic, and they have even isolation area. As I do remember, we are putting the patient with tuberculosis in the isolation ward in Bahri Teaching Hospital. This one almost more than 10 years ago. So this one can be implemented, but they need to sit and to think how they need to restructure it and how they need to do it. So there's nothing difficult. And I think each hospital, unless there's some small hospitals, yes, you can say that they can do nothing regarding that, especially in the admission. And if they are afraid from those who will be in the ward. So if you are implementing a 2-meter distance, so what is the problem you'll get if you admit the patient inside the hospital? There's nothing will happen.
دكتور وهب الله، سعدنا جدا باستضافتك، كانت محاضرة جدا مفيدة. نشكرك كثير، نشكر جميع المستمعين، ونتمنى ان شاء الله نلقاك تاني في برزنتيشنز اكثر باذن الله لقدام. لك التحية ولجميع المستمعين.
الله يكرمك. شوف الناس اللي رفعوا يده ديل اذا في واحد جاهز.
طيب. We wanted to conclude, but let us take the last question.
Okay.
دكتور عماد الدين طاهر. Unmute and دكتور عماد.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته.
كيف أخباركم دكتور وهب؟ كيف حالك؟ مشتاقين والله.
مرحبا دكتور عماد.
تحياتي لك وشكرا جزيلا على المحاضرة الغيمة. شكرا جزيلا، المحاضرة الغيمة جدا. عندي كومنت بسيط جدا. Regarding the healthcare workers who came in contact with COVID patients while they are wearing their BBs, surgical mask and other BBs or N95. So do we have to swab these healthcare workers? This is the first question. Do we have to do swab for them?
Okay.
And also, do we have to isolate them till the results will come back?
Okay.
And do we have to exempt them from the work?
Okay.
These are my questions.
Okay.
شكرا جزيلا على المحاضرة الغيمة.
الله يكرمك، يديك العافية ودي.
يسلم يا حبيبي.
طيب. في question تاني ولا أنا؟
لا, we will conclude here after this question.
Okay. So regarding the healthcare worker, if they are already wear their PPEs, no need for them to be isolated, no need for them to be tested, no need for them to be treated as they have a contact, because they have already wearing, or they have already wear their PPEs. So no, there's no any evidence telling that you need to isolate them, because they have already wear their personal protective equipments. So why you are isolating them? Why you are testing them? Even here in UK, even those who have contact, healthcare worker has contact with a patient who is positive and he's not wearing his PPE, let us say his household contact, he got the symptoms. What he will do, he will be tested first, okay? And if negative, will come to work immediately, even if the test just came now and you are negative, so you will be, you will come to your work. You will not be isolated, you will not be, you will not be tested just like this if you have already wear your PPEs.
شكرا كثير على المحاضرة القيمة. زي ما قلنا قبل كده نتمنى نلاقيك في محاضرات إن شاء الله لاحقة. عارف إنك أنت بتحب to convey messages, to convey awareness messages، وإن شاء الله تحصل لنا الفرصة السعيدة دي مرة ثانية بإذن الله.
إن شاء الله بإذن تعالى.
تسلم، شكرا لك كثير. شكرا لجميع الحاضرين، ونعتذر لو في مثلا ناس كانوا عاوزين يشاركوا بأسئلة بس عشان الوقت. we are exceeding the scheduled time actually. في حفظ الله ورعايته. مع ألف سلامة.
الله يسلمك، يديك العافية.